Seaver, thank you for the invitation. I'll talk about screening for chemical peels. So I say everybody should have a safety checklist. Just like we go to the mechanic with the car, they go with the checklist to see if everything is correctly. We should do this before submitting the patients for especially for a deep peel. And everybody can develop their own checklists and their own safety protocols. And I think that would be ideal. The SOPs. During the procedure, it's also important to continue to monitor the patient. So say, just like the car has the user interface there, which are the monitors of the speed and the temperature of the monitor, of the motor. When we're doing a DPU, it's really important to have a monitor so we know exactly how the blood pressure, how the saturation and everything. And when we were in the wizardry school, we learned how to really check those magical ingredients there. Let's say the poisons we're using on the patients, it's also important to check if they're pure, right? There's this powder there, there's this solution, the basilisk venom and dragon's blood there. It's important for you to check the ingredients as well. That's part of the screening. That's part of the checklist. So let's say I got this willow bark poison from a company, and it had needles, the needles of the willow bark poison. So what I did is I got the willow bark poison there, and I heated to dissolve the needles. They're there. You know, those are crystals from salicylic acid. I'm joking here, but the magic potions, they also need to be checked. Let's say when you get a croton oil, we need to check the color. When you get a phenol, you have to check the color. If phenol is pink, it's not pure phenol. Got it? So it starts there. But then after mixing the formula, you should also check how the formula is going. Let's say if the formula is shaking and mixing, depositing in the bottom, it means that the formula is not stable. So you need to shake more or change the formula for a new emulsifier agent. Here's Dr. Hatter, my mentor. I think he needs a deep peel. I'll try to convince him one day. And now let's go for the main thing of the lecture, which is actually the screening. When we're doing the peels, we usually have these older patients. I saw a lot of patients for acne scars and everything, which are younger. But when we're doing a deep peel, it's usually older patients. So we need to have some kind of checklist to know if they're doing well. There's some basics there, you know, if they have some problems healing, if they form scars, if their nutrition, you know, I consider those such basic things that they are on my checklist, but there's nothing that I ask for a lab or I do another exam for that. I would say if some patients they're older, they take a lot of medication. Of course, I check their kidney, their liver. There's this basic anesthesiologist classification of risk, the ASA classification, which I think applies well for deep peels. So say we try to peel patients who are ASA 1 or ASA 2, that means very healthy patients or with very controlled diseases. They have diabetes, but it's perfect, or high blood pressure, but it's absolutely controlled, and it doesn't affect their lives. So those are the patients that we peel. Extremely exceptionally, we would peel a small area of a patient who is ASA 2, and we never peel someone who is ASA 3. And I consider those checklists very basic. Now, we want the peel to go smoothly with no surprises, right? Our monitor cannot go crazy during the peels. And sometimes, you know, it happens even with the younger patient who's perfect. So anyways, I developed this SOP, a Brown, which I try to make it available through IPS. So I'll ask Christian to have it there on our website for members. And I say that it's like we're circus trapezists. We're going through these very risky things of peeling someone's face with deep chemicals. And we need to have the safety nets. We have to make sure everything goes well. We don't want to kill ourselves. Jackie Stallone, she was a deep peeler, the mother of Sylvester Stallone, and she was a circus trapezist before becoming a phenol croton oil deep peeler. And I'm sure she had a lot of safety protocols there in Miami where she was peeling before Dr. Baker. So now I'll give you two examples so you have in mind, so you adopt the safety protocols. This is a patient that she was very healthy. I prescribed oxycodone for her to take before the peel. Everything was okay, but then the oxygen saturation on the monitor started to go down. She was 96, and then while I was peeling, the heart rate started to increase to 100, and the saturation started to drop a little more. And I had a cardiologist on the room, and the cardiologist said, "Oh, that's just an anxiety. The patient's, because of the pain. Let's just give a little benzodiazepine a little more to relax the patient." And then the heart rate continued to go up, and the oxygen levels continued to go down, and the patient was fine. She wasn't coughing. She wasn't doing anything. And then she continued to raise the heart rate. It was 150, the oxygen levels dropping more. And then I decided to stop the peel. Say, stop. We'll stop. This is not right. Her heart rate's racing. Everything's fine. No arrhythmia. And then she gave a cough. She was having an asthma attack. But she wasn't coughing because she took oxycodone, which suppresses cough. And she had an asthma attack right there. And we had given her a beta blocker to reduce the heart rate. Anyways, luckily we detected that she was with a saturation of 88 by the time we detected the asthma attack. Yeah, we need to know this because here's the thing. After this case, I ask every single patient, do you have asthma? Do you have wheezing on your lungs when you use perfume? And I see some patients that say, yes, I don't have asthma, but yes, I have some bronchitis when it's important to check that because they're breathing acetone and then breathing phenol during the peels, right? And now, another case here, so she had an asthma attack, everything was fine, I completed the peel, no problem. I gave her beta blockers, beta agonists. And now another case, I was doing this peel, everything was fine, the patient was a little more bradycardic, and then all of a sudden she developed this very weird heart rate, which is called torsade points. And I could still talk to her. She was talking, everything's fine, doctor, go ahead, I don't feel anything. Her saturation was fine. The heart rate was super high, but she was, I don't feel anything, go ahead. So if I didn't have the monitor, I would never have known that she was with torsade points. She was asymptomatic. And this happens because of QT prolongation. So basically, there's this interval on the EKG. When the T wave gets longer, then the patient can get into this crazy rhythm. And then after this patient, I started to monitor all my patients. I detected that basically during the peel, they have a QT prolongation. So now part of the protocol, I need an EKG before the peel to know what's the QT interval. So let me show you some videos here. Usually when the patients are more bradycardic, the patients can develop some PVCs, sometimes a bigeminy like that, like one PVC after each beat. The worst case scenario is for them to get into torsade points or a polymorphic ventricular tachycardia. And that's what we want to avoid. So here's, I do an EKG before. This is a patient that would never peel. You can see on the top there, long QT. She needs to change her medication. She could die at home sleeping. So there's a cutoff there. I don't peel patients who are over 470 of QT interval, corrected QT interval. But when they are over 50, I try to do something, 450, I try to do something with their medications. Just so you know, the forbo esters from croton oil, just like Sahas mentioned, croton oil causes QT prolongation, while phenol causes arrhythmia by other means, by sodium channels, other things. There's an app called Credible Meds, which I find very useful to check all the medications that the patient are taking. If the patient is taking one medication that causes arrhythmia, and my patients, they take a lot of antidepressants nowadays that prolong QT. So and even here's an article from a long time ago that mentioned that phorbol esters prolong QT. They block this channel on the heart, the HERG channel, HERG potassium channel. So here's another example: pantoprazole, or even medication for gastric pain can cause QT prolongation. And just so you know, one thing that was detected is when someone is taking a medication that prolongs QT, what really causes arrhythmia is when magnesium levels are low. So let's say if someone's taking a lot of medications and their QT interval is kind of high, it's better to measure magnesium. So this article here that was done on the VA, they checked that only patients with low magnesium, they have arrhythmia, or they have more problems with the QT interval. So Credible Meds is an app. It's a free app that you can check all the medications of the patients we're taking. So just to finalize, this is one of the patients that I think I saved her life because I did the EKG before. She had a very long QT interval, 505. She was taking 3 medications that prolong QT, hydrochlorothiazide, hydroxychloroquine, and sertraline. So what I did, I stopped those medications before the pill. They were not necessary for her life. I started her on a beta blocker and also magnesium supplementation. And then I did a pill. The EKG was fine before the pill. We repeated. And she had some mild PVCs during the pill. Everything was fine. But I think if I had done the pill without doing the EKG before, she would have a severe arrhythmia. So anyways, we keep all these basic safety measures during the pills, but it's important to check some labs before, especially the QT interval, okay? And just to mention here, it's good to have oxygen in the office, defibrillator, beta agonist for asthma attacks, and magnesium if they have an arrhythmia that doesn't spontaneously resolve, lidocaine, which are the standards of the ACLS. So you have to have ACLS training on your staff. Thank you very much.